this presentation involves some interesting cases, but we remove them to our considering the time. So this will be the outline. I'll do a short introduction, present the Philippine healthcare situation, and I figured that we both have a lot of Pakistan and the Philippines might have a lot of similarities in terms of the public health considerations for stroke care. So, short show of hands, who of you have been to the Philippines? I guess none, right? Oh, just one. Thank you, sir. So, you're here, the red dot in the Philippines here. It's a short 13 to 14 hour flight, no direct flight from Pakistan. And it is an archipelago of over 7,100 islands. It depends on whether it's low tide or high tide. It can go up to 7,600 islands. But it's composed mainly of three island groups. Luzon, which is the northmost. The cluster at the middle is Visayas, and the cluster at the southernmost part is Mindanao. And each of these island clusters have at least one or two capitals. So in Luzon, we have Manila over here. In Visayas, Cebu is over here somewhere, and Davao is here. So the Philippines has a population of 118 million, land areas around 300 square kilometers, and half of the population actually occupy the cities. For the longest time now, it has been documented that stroke is the #2 killer in my country. Second to ischemic heart disease. Third is cancer. And it has been consistent in the top 5 leading causes of disability. But due to our geographic challenges, geographic setup, we don't have a lot of information in the small islands. The true stroke prevalence is really unknown. So we do have a lot of groups, and there's a multidisciplinary initiative that wants to improve stroke care in the Philippines, and evaluating the current state of stroke care, the needed resources, and the gaps in health policies and programs is crucial to decrease stroke-related mortality and morbidity effectively. As of now, it is quite unfortunate that the mechanical thrombectomy rate is still at around less than 1%. It's because of all the issues of cost and access. Fortunately for us, we do have support from the government. There is an established legislation that defines the national policy and framework for the prevention, control, and management of acute stroke. And it is enacted by our health ministry. So with all of the collaborative efforts of the neurologists, neurointerventionists, and all the stakeholders of stroke, these were the identified gaps in stroke systems of care. This was taken from a journal article created by our pretty energetic neurologist in Frontiers for Neurology. So we have low government insurance coverage with high out-of-pocket expenses, low numbers of health practitioners, lack of imaging, lack of dedicated stroke centers. We have variable stroke protocols because of the geography and access to resource, lack of infrastructure, inadequate acute stroke and hospital units and rehab facilities, and one of the more important ones is poor community stroke awareness. It's actually quite good that I follow Dr. Sakur's presentation because I have a lot of ideas from what you guys are doing. So let's start with the most important one, which is resource. We do have a national insurance system, but it doesn't really help a lot. For ischemic stroke, the coverage is just about like 500 USD. For hemorrhagic, it's around 700 USD. And more than 70% of expenses are out of pocket for these patients. Considering devices, EF, hospital costs, the estimate for mechanical thrombectomy back home per procedure is around $18,000. Now take that to put it into perspective. A normal Filipino minimum salary earns $5 to $11 a day. So this is the stroke burden in the country is quite heavy because all of these are resource limitations were present. So we also have identified that there's a limited number of healthcare professionals when we're far from the ideal number. As of 2021, there is one neurologist for every 200